Okay, good afternoon again. And the next session is the Industrial Symposium sponsored by AstraZeneca. And my name is Titiwasi Prasad. And again, I would like to introduce again Professor Asu Yokangshio. She is the professor at the Department of Pulmonary Celal Banker University, Manisa, Turkey. And she is the past president of the Turkish Thoracic Society from 2014 to 2016. She is the chair board of directors of GINA, and she is the chair of WHO Global Alliance Against Respiratory Disease. And she is the president of GINA. And today is my honor to welcome again Professor Asu Yokashio for the topic of management strategies to address SABA overuse with anti-inflammatory reliever. Welcome.
Thank you very much. Hello again. Good afternoon. It's my pleasure to be here again for the second time. And I would like to thank AstraZeneca leadership for inviting me to take part in this luncheon satellite. So the title is the Management Strategies to Address SABA Overuse with Anti-Inflammatory Reliever. I have touched this a bit in my morning speech, so I will go into details now. And this is my disclosure. So I will divide my presentation into three. First, I would like to give you an idea about the paradigm shift of asthma management in GINA guideline, starting in 2019 and now in 2023. And then I will address the strategies to address the SABA overuse globally, all the world, and talk about some SABINA trials. And then I will conclude with the effect of anti-inflammatory reliever, and I will share with you the data we have. We know asthma impacts worldwide patients, and it's one of the most common chronic diseases worldwide. And look at the number of the exacerbations per year we have. And for the exacerbations, the severity doesn't matter. All patients are at risk of exacerbation, even those with mild asthma, even those with controlled asthma. So these high rates of exacerbations and reliance on urgent treatments place a burden on healthcare system globally. So this is a healthcare issue. I would like to share with you that, as I have mentioned just a minute ago, that all patients are at risk of exacerbation. You can see here at the left bottom, age and severity, adherence, and even asthma control. Even controlled mild asthmatics have exacerbation, as I have shared before. You can see here now that we know that our asthma exacerbations may be physically threatening and emotionally significant for the patients. You have shared excellent data with us for the environmental and the physiological impact on asthma patients. In my country, not different globally, has a low level of asthma control, unfortunately, same other in Asia countries. And I know that you have 2,200 asthma deaths in Thailand, so it's quite a number. So we have to deal with this. You can see the normal airway. I will talk on the differences of the asthmatic airway. You can see, I don't have the pointer, but please look at the thickness of the bronchial wall. In the asthmatic airway, which is different with the normal airway, the bronchial wall is thickened. And when you have the triggers and have the asthma attack and the muscles also construct, and please look at the lumen that the patient is trying to breathe. So we have those symptoms like dyspnea, cough, and etc. So it's important in the exacerbation to dilate the muscles, but the most important thing is to deal with the inflammation, which makes the bronchial wall so much thickened. So airway inflammation drives asthma symptoms, and not bronchodilators alone, but corticosteroids reduce airway inflammation, mainly inhaled corticosteroids. Look at the airway narrowing, look at the inflammation and the symptoms, and you can see that corticosteroids reduce airway inflammation. Because of that, this is the main treatment of asthma, not bronchodilators, the message that I would like to give today. So see, this is the iceberg, and you can see that the current control, which are the symptoms, pulmonary functions, that's over the level, but future risk is so important. Exacerbation is important, and functional loss is important. You can see that the bottom of this iceberg is inflammation. We are only dealing with the top of the iceberg, but the important thing is the bottom. So the goal of the asthma therapy should be disease control. We should reduce the impairment. We should maintain the normal activity levels, good symptom control, with lowest reliever. And we need to have a partnership, close relationship with our patients. But we need to minimize the risk of asthma-related mortality, exacerbations, persistent airflow limitation, which goes to COPD, and side effects of the treatment as well. So there has been a paradigm change, and Gina, as I have mentioned in the morning session, 2019 made a fundamental change. This was a fundamental change after 50 years of promoting SABA. So for safety, since 2019, Gina no longer recommends SABA-only treatment for step 1 in adults, and all steps, of course, and we need an ICS-containing regimen. It's a fact that the higher use of SABA is associated with clinical outcomes. You can see in this very nice graphic that if the patient uses 3 canisters per year, more than 3 canisters per year, they have the risk of emergency department visits, and they have the risk of hospitalization. Higher use of SABA, this literature is also included in GINA. So if the patient spends more than 12 canisters per year, she or he has higher risk for that. This is very much connected with the mortality, so this is so important. What is the mechanism? What is the pathogenesis under this? Because when you use the chronic use of agonists, there has been a function loss of the receptors, and there will be the reduced bronchodilator effect, and they will need increased dose. That's why when our patients are not under control, they increase the number of the puffs of their SABA, their relievers. So they became a vicious circle, going symptomatic, under control, but using very much SABA. And this is a very nice study of the effects of terbutaline and budesonide on sputum cells and bronchial hyperresponsiveness. Please see the difference of budesonide and terbutaline in FEV1, sputum eosinophils, and PC20. So that is the reason that paradigm shift 2 years after 30 years. So GINA no longer recommends SABA-only treatment. And this is the recommendations of GINA I have shared with you in the morning. I will not go into detail about dispensing more canisters. And we know the result is the solution is inhaled corticosteroid, because they reduce the risk of asthma, and they reduce the hospitalization and exacerbations, and also they reduce the need for oral corticosteroids, which we do not want, we do not want for the systemic effects. So if we don't use SABA, what is the alternative? We need to have a safe and effective alternative for the relief, for the short relief of the symptoms. So after 50 years, GINA has recommended that we're not going to use SABA only in each step, in every step of the management. So changed the recommendation in 2018. So this was the background of the shift. Let's come to the SABA overuse strategy, SABA overuse status around the world. Would like to ask this question: is there an evidence for the safety and the efficacy of SABA-only treatment? We have evidence for the inefficiency and unsafety. So what is the consequence of SABA over-reliance? I will share with you the data. Unfortunately, SABA overuse is continuing increasingly globally. That's a global point. And let's share with the Turkey and Thailand perspective. You can see asthma prevalence is a little bit lower in my country, and it is in the top 10 cause of that, which is in Thailand. It's the 5th asthma death in Asia, which is quite a number. And also 24% and 28% of SABA overuse in our countries. And also purchase SABA over the counter, which is 10% in my country. And your country, the price also differs because SABA is cheap. And ICS formoterol is expensive, I know this. And these are the Sabina trials I have mentioned before. This was a program. We had the Sabina 1, 2 studies. They were retrospective studies. And Sabina 3 was a cross-sectional study around the world globally. And you can see here over 24 countries had investigated this trial. And you can see that SABA over prescriptions, and which is 3 canisters per year, and over prescriptions, which is 10 canisters per year. I have shared with you the results. Look at Asia, which is the lowest one, so it's good for Asia, but it's still a problem. But for Latin America, for Africa, for Middle East, the numbers are really high, SABA overuse. And these are my country's number, 24%. So what is the reason? What is the outcome of this overuse? There is a nice, not very nice, a poor correlation, I must say, because when you increase the number of the SABA prescriptions, you lose the control of asthma patients. So you can see here, as the canister increases, the control of the patient decreases. There is a relationship because of the vicious cycle in the pathogenesis I have showed you. And this is also with the severe exacerbations. While the number of the canister are increasing, the number of severe exacerbations are also increasing. And also, accordingly, the use of systemic steroids and the mortality is increasing. So this is a very, very attractive outcome. So we should think about this. And because you know that after 3 cancers per year, we have 40% increase in the severe exacerbations. So as a conclusion, I might say that 38% of the patients were prescribed over 3 SABA canister in the previous year, and almost 1/5 were prescribed more than 10 SABA canisters. And also, this is so important, 77 of the patients who purchased SABA over the counter had already received prescriptions from their physicians, but they go to the pharmacy and get additional SABA. So this is a problem. And we might say after the results of the Sabina 3 trial, SABA over prescriptions are very widespread among the regions and among the countries. So the increasing this SABA canister is linked to poor asthma control and increased rate of exacerbations. So these findings provide support for practice, and we need a policy changing to reduce over-reliance on SABA. I hope I can convince you about the bad outcomes of the SABA overuse. Now I will come why we should use an anti-inflammatory drug together with a bronchodilator every time. I think you can also experience with your patients that before starting an exacerbation, symptoms start to increase. And there is almost a 5 or 6 day period where we can also have impact on this. In this period, many of the patients use their SABAs. They increase their SABAs because they have symptomatic. And these SABAs do not work, and the patient goes the peak of symptom worsening and the exacerbation. So there was a theory that if we can intervene with an anti-inflammatory drug, can we prevent the exacerbation? So the answer is yes. After all the data we have, I'm going to show you. Here, we all said from the morning that asthma is a variable disease, variable symptoms, and variable pulmonary function. And symptoms increase beyond day-to-day change, and these variability leads to exacerbations. And the symptoms make the patient the need for increased reliever use, as you may see here. Let's focus on one exacerbation I have showed you. Here, the symptoms go up and the functional lung function is worsening. And when the symptoms increase, the patient starts using SABAs. And inflammation also increases. And also, it doesn't prevent the exacerbation. And when the exacerbation occurs, we use systemic corticosteroids. Now you can see here at the pills or parenteral. So SABA reduces the consequences and symptoms may reduce, but not the cause of underlying inflammation. So that is the point. So if the inflammation increase, if we intervene with an anti-inflammatory drug like you see here, you prevent the exacerbation, you prevent the symptoms, and you prevent the lung function worsening. Instead, you have an improvement in the lung function as showed here. So we need to use the anti-inflammatory drug when the symptoms start. So that's the proof of this. So anti-inflammatory reliever, comparing with only reliever, treats both the cause and the consequences. So I'm happy if I can confirm this with you. So that is why Gina changed the steps and leave as the reliever ICS formoterol as the first choice, as the preferred choice, because in this way, patient never comes with only SABA. But in the second track, we can use the reliever of SABA, but in these patients, the compliance to the maintenance treatment of the patient is so important, because if the patient is not compliant with the maintenance treatment, he or she will come with SABA alone. So these are the figures: review, assess, and adjust. I'm repeating. This is the first preferred track, reliever. Look at the reliever, and the second one, the reliever. So we have a huge evidence on step 3 and step 5 for smart approach. But for mild asthmatics, we have 4 important studies that I would like to share with you. I have mentioned Sigma 1, Sigma 2, practical and novel start studies. You can see here in Sigma 1, we have almost 4,000 patients, 52-week and double-blind randomized control study. And those are mild asthmatics. And novel start, we have 675 patients. It is still 52-week open-label randomized study. And also in Sigma 1, budesonide formoterol as needed use in mild asthmatic, increase, 14% increase a week being well controlled. And please look at the dose, 83% reduce for in the median daily ICS dose versus budesonide maintenance. So maybe in the mild asthmatics, which are not compliant because they don't have symptoms daily, so they don't use their ICS. But whenever they need it, they're going to use these ICS formoterol, and they will have the necessary anti-inflammatory in their daily life. So in the novel start study, we have 52% lower mean daily dose with the same control level. This is Sigma 2, almost 4,000, and the practical study is a real-life study, which is very important, and it also includes the FeNO measurement. In Sigma study, we have 75 reduction, and in practical study, 42 reduction in the median ICS dose. So with this evidence, Gina made a recommendation and showing these slides, comparing with as-needed SABA or comparing with low-maintenance dose ICS, which I have shared with you, there is a reduction in the exacerbation with this issue. And the new evidence also added, there has been a meta-analysis of these 4 trials, which is almost 10,000 patients, and we can see that there's a 55 reduction overall in severe exacerbations. And also this evidence is very much serious with the patients previously taking SABA alone. And with those new evidence, Gina says that this is important to have almost 55% and sometimes more percent reduction in those mild asthmatics. In moderate and severe asthmatics, we have a huge amount of trials which has been started in 2004. And these are the very important studies. COMPASS and AHEAD studies are the ones using the higher dose of ICS LABA, and it is almost 10,000 patients. So it's a real evidence. You can see here in the blue bar that the budesonide anti-inflammatory reliever and maintenance treatment made the greatest reduction comparing with the budesonide SABA as needed, budesonide formoterol plus SABA, budesonide formoterol plus formoterol, and fluticasone and SABA, fluticasone salmeterol and SABA. So in all cases, this approach works very good. And this is an interesting study, only comparing the reliever SMILE study to reducing the risk of severe exacerbations. You can see one hand is the budesonide formoterol as needed, and the other one is the terbutaline as needed, and the other one is the formoterol as needed, which we do not support to using LABA without any ICS. But you can see that there is 27% versus formoterol, and there's 45% versus terbutaline. And that was just a reliever comparison. And you can see here, this approach is more effective in reducing exacerbation to SABA plus same dose of ICS LABA. So I can say that we can give everyone as needed and when needed. This is a cartoon to explain this. So for the COMPASS study, this is a study with the high dose, using high dose maintenance treatment. And you can also see the numbers in the arms. And here, which is a head-to-head study design, there was a 39% reduction in the rate of severe exacerbation versus higher dose of ICS LABA plus SABA. And please, I would like to draw your attention here, 25% lower ICS dose. So those are the patients who needed higher ICS dose, and you can reduce the dose, as we have just discussed before the session for the question of Omar, that if you don't want to increase or you cannot increase the dose of ICS LABA combination, switch to SMART approach so you can lower the dose and have better outcomes for the exacerbations. So this is the question. In patients with poor control, shall we step up the treatment or adjust to MART and remain on the same dose or lower dose of ICS LABA? And I can show you the trials in moderate and severe asthma. You can see here lots of trials, and anti-inflammatory reliever plus maintenance in this step 3 and 5 patient reduce the exacerbations when comparing with the same dose, higher dose, or the highest dose of ICS LABA SABA. You can see the graphic here. I cannot show it because I don't have the pointer, but it favors to the ICS formoterol plus reliever use. And this is also an important study that is showing us, this is a systematic review and meta-analysis, MARVEL, and time to first severe exacerbation. And also here, the first one is the comparator arm, stepping up the treatment, and the other one remaining on the same treatment. And in both of them, almost 30% reduction in the exacerbation, as you can see here. So the GINA treatment figure therefore promotes or suggests or recommends track 1 as the reliever in step 3 and 5. So we are again saying that we are proud to be celebrating the 30th year of GINA, and I would like to share some examples with you that in the world, there are some SABA-free hospitals, like in Brazil, in Saudi Arabia, and we were the first SABA-free hospital in Turkey. I would like to share the video we have shared in our university website. Sorry, it's in Turkish, but we have subtitles in English. Can we have the voice?
Merhabalar, ben Profesör Doktor Arzu Organcıoğlu, Celal Bayar Üniversitesi Tıp Fakültesi Göğüs Hastalıkları Anabilim Dalı öğretim üyesiyim. Ayrıca Dünya Astım Birliği (GINA'nın Dünya Başkanı olarak görev yapıyorum. Astım çok sık görülen kronik solunum hastalıklarından bir tanesi ama şanslıyız ki astım kontrol altında tutulabilen, tamamen normal yaşantımızı sürdürebildiğimiz bir hastalık. Astım ataklar halinde gelir ve biz bu ataklar zamanı rahatlatıcı ilaç kullanırız ama hastalığımızın temel tedavisi hava yollarımızda oluşan mikrobik olmayan bir iltihabı önlemek için kullandığımız anti-inflammatuar dediğimiz koruyucu ilaçlarımızdır. Astım hastalığının temel tedavisi, koruyucu tedavisi anti-inflammatuar dediğimiz her gün düzenli kullandığımız ilaçlardır. Eğer biz bu ilaçları kullanmadan kurtarıcı, kısa etkili kurtarıcı dediğimiz SABA olarak tarif ettiğimiz ilaçları kullanırsak hastalığımızın çok kötü yan etkileriyle karşılaşabiliriz. Ölüme varan sonuçları olabilir. O nedenle biz göğüs hastalıkları uzmanları olarak kurtarıcı ilaçların kullanılmamasını tek başına mutlaka ve mutlaka koruyucu ilaçlar olan inhaler steroidlerle birlikte kullanılmasını öneriyoruz. Bu nedenle elimizdeki çok güçlü kanıtlara dayanarak Celal Bayar Üniversitesi Tıp Fakültesi Göğüs Hastalıkları Anabilim Dalı olarak tek başına SABA kullanımını hastalarımızda önermemekteyiz. Celal Bayar Üniversitesi Tıp Fakültesi Hafsa Sultan Hastanesi Başhekimliğine ve Tıp Fakültesi Dekanlığımıza sonsuz teşekkürlerimi sunmak isterim. Hastalarımızın tümüne sağlıklı günler dileklerimle sözlerimi bitiriyorum.
If you have any questions or any feedback, I will be more than happy.